So we're here continuing to go through varying things so that as I've said before, what I'm doing is building a case for why I say the things I say, why I take the positions I take. So this is another installment in the series I'm calling Don't Believe the Hype. So the primary thing that we're aiming to talk about here is indirect techniques as an example of how many things that are claimed that are different really are very similar or essentially exactly the same aside from very small procedural differences. So if we're looking on the surface of things, if we take the words that are said, then we can suggest that these things are different. If we look at the actions and the goals, indirect techniques, indirect methodologies are essentially the same. So what I'll do is I will take you through some information that's held in textbooks. The reason I've gone to textbooks is because they're a fairly standard resource that the majority of people in the osteopathic profession would have access to across the world. Now, not everybody's going to use the same textbook, not every textbook would be considered the same quality, and that's fine, but my aim is to go into these textbooks because there's a high likelihood that most practitioners around the world in the osteopathic profession have encountered descriptions that are essentially the same, and people who are outside of the osteopathic profession looking at techniques would have seen these things. So this is, again, we're coming out of textbooks, this information is coming out of textbooks. I've heard this outside of textbooks, but this is just a way for me to build the case to understand that these things have the same goal, right? So all these indirect methods essentially have the same goal, and they're achieved through minor differences in procedural steps, right? So the books that this comes from, Foundations of Osteopathic Medicine, and An Osteopathic Approach to Diagnosis and Treatment. So with specific respect to when we speak about functional positional release, or FPR, Stanley Shiowitz was one of the authors on this textbook, and he's the person who's essentially credited for creating FPR. So his descriptions, or the descriptions that would be contained within a work that he made, could be considered as close to a primary source as you're going to get. That said, that doesn't necessarily contribute to the point or the case that I'm building, but it is something of interest. So if you're going to talk about an appeal to authority, well, it doesn't really get closer to authority about something that was created than the person who created it, right? I would say that appeals to authority sometimes have value and other times are barely grasping at straws. So I'm bringing it up essentially in the effort to show you that there is an authority, but that I'm not placing the weight on the authority to build my case, right? So these are the ones that we're looking at. Now, at first, we're looking at facilitated positional release. So this is just, what I did was I took screenshots of pages instead of kind of scanning through the book, because then what happens is it becomes very confusing for me to search through as I'm going through this as well. It becomes very visually jumbled, right? So that's facilitated positional release, and this is written by Stanley Shiowitz. So it's not going to come up all that clearly on the screen just because I took a screenshot and I'm enlarging it. But this is written by Stanley Shiowitz about facilitated positional release. Right? So we kind of get into this, if it will do what I want it to do. There we go. So I'm going to read some quotes from these textbook descriptions. So we're going to go through facilitated positional release, functional technique, strain counterstrain, and ligamentous articular strain, or BLT, balanced ligamentous tension. So right here we're looking at FPR. And my general contention is that all indirect methodologies, your primary goal is to make the soft tissue soft. So you're going to ease, and you're doing whatever combinations of motion is required to get the ease in the soft tissue. So the soft tissue needs to go soft. Okay? So I'll tell you my contention beforehand so that you have some introduction to it, and then as we go through, I will essentially be pointing at the places where those are the common elements. So this is about FPR. This technique uses a modification of indirect myofascial release techniques enhanced by placing the region in a neutral position and adding a facilitating force of compression or torsion. The advantage of this technique is its ease of application, speed of response. In addition, if the desired results do not occur immediately, it may be repeated, or other methods of treatment can be added. Treatment is directed toward the normalization of hypertonic muscles, both superficial and deep. Right? Shiowitz is telling you he's taken some of the concepts from indirect myofascial release, and what he's done is taken his concept of neutralizing the anatomy, so taking some tension that would be built into a system or built into soft tissues if it was in a non-neutral place. So if this is kind of where my hand likes to rest and I do this, you've increased some soft tissue tension. If my hand likes to be here, then that may be the problem. So what I might do is kind of neutralize it, or neutralize a wrist. So if a wrist is over here, bring it back to neutral, and then you start to go more for that soft tissue ease. So you go to biomechanical neutral and you aim for easing soft tissue. Right? But he's telling you that it's about soft tissue, and his aim is to soften that soft tissue. Right? There's different explanations that are included in it, talking about motor tone and things of that nature. But the aim, the behavior, the thing that you're looking for is softening of soft tissue. A facilitating force is then added that consists of compression, torsion, or a combination of the two. Now, one of the things that I want to be clear on here is I'm putting this in because when I talk about activating forces in a previous video, I talk about having an organized approach to adding activating forces in. And I would go compression, distraction, torsion, and shear in that order, because I'm trying to figure out in a clear way which one works or which ones work together. And when you're going indirect, I will tell you that from experience, sometimes softening of tissues, you would think that softening of tissues would best happen when you approximate things because you're shortening those tissues. However, there are situations in which traction or distraction, pulling tissues apart, gives you that experience as a practitioner of the tissue softening. They may not actually be softening in a measurable way other than the experience of it, but you're going to that ease. So this sentence from Shiowitz said most people will say compression and torsion for FPR, one of those two. But Shiowitz does write occasionally it may be necessary to use a traction force rather than compression. So Shiowitz is saying from experience, sometimes when going indirect and trying to get that soft tissue to go soft, you might need to use a counterintuitive motion. Right? So the reason I say go through your activating forces in an organized way is to identify the one or the one that works or the ones that work together. Be it compression, distraction, those usually wouldn't work together. They defeat the purpose. But usually what you're looking at is compression or distraction. Those are kind of the big ones. And then torsion and shear as activating forces would complement. Or what you might get is a situation where the big ones, compression and distraction, don't work, and then torsion or shear do in some combination or on their own, right? So if you go through it in an organized way, you can either identify the one that works or the ones that work in combination, right? And this is something that Shiowitz is noting, even though most people say compression or torsion for FPR, he's saying you may need to use distraction as well. I'm going a step further and saying go through all activating forces in an organized fashion, figure out the one that works or the ones that work in combination. So your general step-by-step overarching concept here for FPR, the physician modifies the patient's sagittal posture in the region to be treated. Now that's when you're working on the vertebral column, right? In other areas, biomechanical neutral or relative biomechanical neutral. Facilitating force is applied. This is either compression or torsion, or possibly, as Shiowitz has mentioned, traction. The large muscle is shortened to the somatic dysfunction is placed into its freedom of motion. So the biggest muscle in the area, you're aiming to shorten that if you can, or if that's not necessarily working the right way, then the parts that you're working with are going to freedom of motion. The way that you figure this out, the way that you identify this, isn't necessarily simply freedom of motion, but the most consistent way is softening of the soft tissue. Right? Now, if we move into functional technique, primary person spoken about with respect to functional technique is William Johnson out of I can't remember if it was Michigan State or the University of Michigan. I believe it was Michigan State. The basic idea with the procedural steps of functional technique is sometimes what they're talking about is gross motion to identify a smaller motion. So I will talk about macro identifying micro, but there is a component of functional technique where you're looking at a gross motion to identify a smaller problem. They do talk about using a compression test in an area, because you would expect compression to make something go soft, but their suggestion within functional techniques, if you use a compression test, something goes tonic, that's a positive finding, and that's the thing that you should be working on a smaller piece. I won't agree with that or disagree with that. I will say that's what they state. I would say that that's almost too rigid of a statement for me to stick to. I'm looking for the thing that sticks out, but in functional technique, they would suggest a compression test on some things. So we're just going to kind of go through the guidelines here. Initial introduction of motion in any one elementary direction is small, not range with minimal forces applied. So you're essentially, you found the problem and you're going towards ease, right? You're going to begin to go towards ease. Motion directions are toward a sense of immediately increasing ease. So let's just say you're going to be organized about this, and the primary problem is in the sagittal plane and somebody prefers to flex. You have them flex first, so you immediately increase ease. Then what you can do is test if in that ease, in flexion, if they like to go left or right. Say they like to side bend left or side bend right, so you keep that flexion, side bend left. If there's immediate ease on that motion, you can keep going that way. If there's immediate tension, you don't go that way, you would go right. And then you can do the same thing with rotation, right? This response manifests as decreasing sense of resistance to pressure at fingers monitoring the tense dysfunctional segment. So again, the tense dysfunctional segment, you're looking at that thing that's tense, and the ease is going to pop up there. You're going to feel the softening. Number 3, single elements of rotary and translatory directions are combined, affecting the control of an eventual smooth torsion arc for body movement. The order of introduction of these elements is not important. So they're saying you could do rotation followed by translation or translation followed by rotation. You can switch them. I would say for your ease of application, whatever you're going to do, keep the order the same. You'll keep track of it better. You won't miss stuff. At least early on. Later on, after you've kind of done the same thing forever, freestyling and going in different ways becomes a bit easier experientially. That may not absolutely be the truth, but the experience is going to make it feel that way. Number 4, the final step of the functional procedure involves request for a specific direction of active respiration, whichever direction inhalation or exhalation contributes further to increasing ease. Again, ease, 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 right? For example, if inhalation, the request is for the subject to take a deep breath slowly and hold it briefly. So you'll figure it out, you test it, you test inhalation. If that increases tension, then you have them exhale, or vice versa. Number 5, the respiratory interval, adding to a continuous feedback of decreasing resistance, allows the operator to fine-tune the combination of translatory and rotary directions. The objective is to reach a sense of release of tissue tension at the fingertips. So the area that you're monitoring, that is the tense area, the tissues should ease, which are continually monitoring response at the dysfunctional segment. The release of restraint in the motor mechanism allows a return to midline resting unobstructed by any sense of resistance previously encountered in the return direction. I'm not going to completely agree with that, but I am going to stick with those procedural steps that essentially says, go in a specific order and get ease. So where you found tension, move in directions that increase ease. So the overall arc of functional technique ends up being move in a direction that increases soft tissue ease. There are procedural steps that are implied here, but just as with FPR, functional technique aims for ease in soft tissue that's being monitored. Make the soft tissue soft, okay? LAS, BLT, essentially what you have is the 3 steps are disengage, exaggerate, and balance, okay? Just 3 steps, but the disengagement, exaggeration, and balance all essentially center around ease, right? The reason it's called indirect is because you're going in the direction of ease. You're looking for that freedom. The way to tell that freedom is, again, with that sense of soft tissue softening. There can be argument there where people would speak more about the freedom of motion. I would suggest to you that you are better off talking about the soft tissue Softening, it's more experientially identifiable and trustworthy, especially over time. Motion testing has acceptable reliability, inter-rater reliability, depending on where you're looking. Sometimes, other times it has low inter-rater reliability. Its accuracy or its validity may be on the low side because it may not be doing what you're saying it's doing, right? So the test you're performing may not be testing what you think it's testing, it may be testing something else. So you have to be careful with it and what you infer from it. But the idea is you can make the argument that you're looking for freedom of motion, but especially if you're looking at small motions, I would tend to trust it less. I trust differentiation in motion potential in a large motion much more than I do in a small motion. So I would say you're better off at looking for soft tissues going soft. That would be my approach, and you can disagree with that. That's fine. But you kind of look into this disengagement. To disengage, the osteopathic physician must use either compression or decompression. So squish it or pull it apart. That's your first move, right? Pushing a joint or tissue together or pulling it apart generally accomplishes this. Again, generally accomplishes this. They're giving you the opportunity to understand that sometimes your first move as compression or retraction may not be the right one. You may have to go into torsion or translation or rotation or translation. The more common approach is the use of compression. Again, they're telling you more common, not absolute, but more common. If you read this as, oh, most of the time I go compression and you always go compression, then you'll miss the times where distraction is more appropriate. You'll miss the times when translation is more appropriate. You'll miss the times when translation or torsion. So you'll miss the times when those are more important, depending on how you start. There may be a more appropriate way to start. If you have an order in which you do these things, compression, distraction, torsion, and shear, you will identify the one that works or the ones that work work well together. They complement each other. So you've got your disengagement. They're saying usually you compress, sometimes you distract, other times maybe something else. I would tell you go through them on purpose. Go through all of them on purpose. Exaggeration after disengagement, the joint is tissue is taken into the direction of the injury. They use the injury. You'd have to trust that the report of injury told you the motion that it took and there was no other possible motions. So I would be careful with that clinically. I would go on what I'm able to find, not only what's reported. I take what's reported, I appreciate it for what it is, I appreciate the uncertainty that it provides. I will tend to follow the motions that I'm able to create ease in more than sticking with the previous thought of possible mechanism of injury. Mechanism of injury matters, but it is not the only thing that I'm going to think about. I'm not going to trace the injury, I'm going to identify ease, clinically speaking. This exaggerates the position of the diagnosis of relative freedom, right? So you're going to freedom, you're going to ease. Because the joint or tissue was taken beyond its physiologic barrier and remained dysfunctional by the injury, it fails to return to its physiological position. Close to the point of injury is the most likely location to find the dysfunction. So basically, they're using a lot of words to say go to ease, go to its dysfunction. So if you diagnose something, the wrist likes to go this way, they're saying go this way based on your diagnosis. Okay? I would say that's fine if you're using these procedural steps, but you're still going to ease. You're going to ease. You're going to ease. The best way to identify that ease is ease or softening soft tissues. That's the best way to do it. That's the feeling of freedom as a practitioner, right? So you're going to be able to identify that ease in soft tissues because things will feel softer. The balance point, establishing the balance point leads to resolution of the somatic dysfunction. So that balance point, essentially, although it's not specifically said here, is that what you're doing, that balance point is where ease happens, where all the tissue comes off, or all the tension comes off the tissues. Again, you're making the soft tissue soft, right? That's LAS, okay? LAS, BLT. Disengage, exaggerate, balance. The procedure is squish or pull first, where, say, FPR is flatten first, go to ease, then squish or pull, right? So then compression or traction, whatever you have to do. LAS, BLT, you squish or pull first, FPR, you do it last, right? So procedural differences. Functional technique, whatever you do, go to ease first. Get it to go as soft as it can in initial motions. In the small initial motions, make it soft. They all are going to make the soft tissue soft. Okay, that's more LAS. Yeah. So now we're looking at strain, counter strain, or counter strain, or Jones technique, depending on where you come from. Basically, I've heard this described well as fold and hold, right? You find the tender point, right? So the tender point's here. You move around for that ease. So the soft tissue should ease, and the subjective report of the patient, the tenderness should be dropping. If you ask, so I poke here, and the patient says, ouch, and then I do this, and I say, does it hurt more or less? And they say less. Well, then I'm in a good position, and I will continue to go until they are both saying it hurts less, and I also have that sense of ease. So you're monitoring a tender point and you're moving to ease. The idea of fold and hold is take tissues towards, kind of fold tissues in towards the tender point. Does that always work? No. So the reason that I would have a bit of a challenge with the term fold and hold is because it suggests to you that that's the way to go. And I would say that if I'm looking for the easing of soft tissues and the reduction in tenderness at the monitoring point, I would suggest, again, make the soft tissue soft. If you make the soft tissue soft and that allows the patient to say pain has dropped off, you're going the way that you want to go. If you stick with fold and hold as your directive, then you're going to at least fold and hold right away, and you're going to wonder why it's not working. And I would suggest to you that, again, very, very purposely go through directions and find the ease. Go through your motions, find that ease, and it will be the most appropriate outcome. Yeah, fine. So we look at this, find the most significant or relevant tender point, establish tenderness scale, continuously monitor tender point, tenderness and tissue texture, place the patient passively in a position that results in the greatest reduction of tenderness and the tissue texture abnormality at the tender point. So as I said, dropping tension and dropping subjective pain, reported pain. Does this hurt more? Does this hurt less? Right? Again, soft tissue soft. So no matter which one of these that we look at, and it says maintain the position for 90 seconds or until the tension drops off, or like you feel a release. So beyond 90 seconds, you don't seem to get more out of the maneuver. So if it hasn't done anything in 90 seconds, change. If it fixes itself before 90 seconds, you can kind of come away from it. But the thing that I've highlighted here, it may be appropriately visible, it may not. I'll try to zoom in on it. The myofascial tissues in this, so this is again just leading into my concept, soft tissue soft, soft tissue soft, make the soft tissue soft. The myofascial tissues, the tender point, will begin to relax as the patient is moved towards the correct treatment position, right? So no matter which one of these we look at, I would call these the big indirect techniques. Other people can disagree. Other people may have one that they prefer. They may have one that they'd like to talk about a little more, and that's fine by me. But the common element is make the soft tissue soft. So you can talk about that as going towards the direction of ease. That's fine. There's nothing wrong with that. My challenge with that is that some people will then say, well, I diagnosed it as side bending right, so I'm automatically going to go side bending right. When you side bend right and you're not monitoring the tissues and the tissues don't soften, it doesn't seem to be clinically relevant to give you the outcome you're looking for. That reduction in tissue tension, that ease, that freedom of motion, that drop in tenderness, it doesn't give you what you're looking for. If you monitor the area that you're interested in, you make the soft tissue soft, and you do it in a systematic way, compression, distraction, torsion, and shear in that order, or in your order, you can go torsion, shear, compression, distraction. It is not of concern to me which order you go in. I would suggest it's useful to go in an order, because then you identify the one that works or the ones that work together, as I continue to kind of harp on. If you're just going on biomechanical diagnostic, in whatever way you believe you've done it, I would suggest that you're going to miss the boat. All of these have the common element of making the soft tissue soft. If your goal is to make the soft tissue soft, you're probably going to get a clinical result. Whether or not it improves the quality that you're talking about, let's just say it's reduced, the gamma motor neuron gain, or it's interfered with the gamma loop. Let's say you're talking about histology of tissues. Probably hasn't done any of that. Maybe it has, maybe it hasn't. And maybe it's done it in a measurable way, maybe it hasn't. The thing that seems to be consistent is that the patient is subjectively able to report a greater ease of motion, a greater freedom of motion, greater comfort. Those are very important things. The scale that's the most important is the patient scale. So these indirect methodologies, if you apply your concept and you're trying to make the soft tissue soft, it doesn't matter. It doesn't seem to make much of a difference which procedural steps you follow. What seems to matter is that the common element is making the soft tissue soft. So there's differentiation between these, as I've said, on procedural steps, the how you do it, the steps that you take. You can create varying numbers of steps or varying orders of steps if you keep the central element that the soft tissue goes soft when monitored. You're doing indirect appropriately. You're doing indirect in a way that seems to have clinical relevance. I've seen people say that, this technique is better than that one, or this technique is better for this situation. These are superficial procedural differences. The thing that's entirely the same is soft tissue goes soft. I've heard varying techniques referred to as technologies. These are treatment technologies. That's fine if that helps you keep it straight in your head. I would say that separating out technical approaches and technique systems as different really misses the central components of them. I would say that really all you're getting, or the thing that you dominantly get when you separate these things out, is a history lesson. And I'm not against history lessons, but for the clinical relevance and for the teaching utility, if you're separating these things out with long lists of procedural steps, you're increasing cognitive load on students, you're increasing cognitive load on practitioners because they're trying to think through these steps. Where if your aim is be organized, or the way that you communicate this is be organized, have a specific set of steps that you go through, that you've created, that makes sense to you. Your goal is to make the soft tissue soft. You're activating forces in some order: compression, distraction, torsion, and shear. Put those together however you want to put them together. You will identify the one that works or the ones that work together, and you'll have an appropriate clinical outcome, or you'll have no outcome. If you have no outcome, you've learned it wasn't the appropriate way to go, or it's not going to respond. The aim here overall, again, is to show you how similar these things are in their goal, which is making soft tissue soft, going into ease. There are superficial differences in procedural steps. So in noting that we can at least see on some level superficial differences in procedural steps with the same goal, my suggestion is to stop acting as if these are really all that different. It's the difference is window dressing. So behaving as though one is better than the other, one set of steps is better than the other, is really almost accidental and experiential. You've identified that when you take these steps, you seem to get a better result. Cool, fantastic. That's your experience. My experience may be entirely different. The thing that unites all these, if we teach from and we treat from, have a clear set of steps, make the soft tissue soft, indirect will do what you want it to do. I have had experience where people were taught to go in the direction of biomechanical diagnostic and not necessarily aim to make the soft tissue soft, and indirect wasn't working for them. They asked me a question, I told them something, I made them try it. And again, this is experiential, so I'm coming from an experiential place when I tell the story. That I told them to make the soft tissue soft, and all of a sudden it was the first time indirect worked for them. So the hype here is saying that these are really all that different. Indirect techniques are different. Different window dressing, different procedural steps. Sure, fantastic, great. Different procedural steps, same goal. Let's go for the same goal. Be organized and make the soft tissue soft, indirect will work. So the hype is acting as if these are different. Don't believe that hype. Stop spreading that hype.